Hi, it's Petrina Yamani, and I'm back for one of the last in the series on social sciences. And today I am going to be doing personality disorders. And it's definitely for anyone who wants to learn more about personality disorders. But, for clinicians, it's going to be a nice refresher. And for everyone else, who just wants to learn, that's why I'm doing this video, because it's pretty interesting. And so people want to know, so that's what I do, right? If you want to know about something in the social sciences, I'm definitely going to try to bring it to you, right? So this is the last one of this specific genre. I have the next one, I have the prayer workshop, and that's completed, and that will be sent out tonight. And then, of course, we have the paid clinical one on attachment, which is $5. And there's was only two clinical workshops that were paid. The last one was on trauma, and that was $10. It was really good. It went really well. And so hopefully this one will be just as good. And then that's all in the series. We're done. The prayer will be the last one sent out for the last day of the year of 2021. And so, yes, we stuck to our goal. I got a little sidetrack there with doing my dissertation. And so that needed lots of attention. And so now I can finish the series. And so thank you so much for seeing all the videos. And they were very interesting topics, I think. And it was nice having different people come in and present and share their knowledge on the different topics. And it was really nice working with them, with Felix, with Babette, with Agazit Freedom, and a special appearance in the prayer series. And I don't want to say anything about that in the prayer workshop. So that'll be a nice little surprise. All right. Thank you so much for being here. Let's get started. Okay, personality disorders. So I'm a licensed professional counselor and in two states, in Virginia and in Maryland. And I'm a PhD candidate. I'm studying resilience, and that's what my dissertation is about. So there's just an introduction. I'm gonna move this. There's something that's in my way. Okay. So just an introduction on frequency and duration. That's the most important part. When you look at a personality disorder, it's very important to look at the frequency and duration. Frequency in how are you seeing the symptoms of the person, at how much of it you're seeing. Is it daily? Is it once a week? And so it's pretty much how often you're seeing the symptoms. And duration is how long you're seeing the symptoms. And so all clinicians, doctors, nurses, social workers, physician's assistants, licensed clinical counselors, we're all looking at these two things when we look at the symptoms of a person in order to diagnose. And so frequency, again, how often, and duration, how long are you seeing the distress or the symptoms? Duration is like how, is it over a 6 months period you're seeing it? Is it over an acute amount of time within a month? And then symptoms go away. And so this is very important. And that's why I put it as number one. And when we say symptoms, it's more of a distress, like how distressed is the person, which leads to functioning. How is their functioning in their everyday life? You know, is it mild? Is it a mild case where they can function? Or is it more severe where it's affecting their functioning and how they're coping in everyday life to do life skills, to sleep, eat, take care of themselves, follow through with their responsibilities, be able to work, how are they with school, their stressors. And so those are the things that we look at. Now, when we go through this, there's something called, I think I have that syndrome. It happens with every student, every person who looks at any kind of diagnosis on anything, whether it's physical or mental or emotional. And we think, wait, I have that. The other day, this happened, this, and then, oh yeah, oh, I had both those together. You know, you start thinking, I have it. And so it's very common. Okay, it doesn't mean you have it. It's just very common. We can't help but to reflect on ourselves to see if we have it, right? Have this syndrome or this illness. So you most likely will think of yourself or even someone else like, oh, that makes sense for, you know, Uncle Bob or Aunt Gwyneth, or right? So get a clinician, like have them go and be assessed, okay? Or have yourself assessed if you really believe you do have it. Very important to say, go and get checked out, you know, go and see if your findings are correct. Don't just diagnose yourself, okay? So I'm just giving basics here. I'm not giving a full diagnostic on someone or you that I don't know. It's just for our understanding of how personality disorders work, okay? All right. So there's a difference between personality disorders and illness disorders, which is important to know because they can really be confusing, especially with diagnosis. And a personality disorder you have all your life, like it presents maybe from 6 on, some personality disorders. So it's something that is part of your character, of who you are, of how you have been living life, versus illness disorder, which is more of a behavioral disorder, a dysfunctioning that you usually onset is like 16 for some, or 15. Some diagnoses are younger, but it's basically about behavior and cognition, how one's thinking has changed due to some dysfunctional event or experience that they've gone through. And so it warps behavior and it warps thinking. And so that's the difference. So we're going to be talking about personality disorders where this person has it, most likely has had it for all their lives. And so we're going to be looking at the DSM, the current one, which is DSM-5. And the personality disorders are categorized in clusters, cluster A, B, and C. And they categorize these, and you'll see from the presentation, you'll see they're all separated within their category of A, B, and C. And so those that are in cluster A they're considered the suspicious, you know, suspicious, or they have suspicion is the best way I could say it. The categorization for cluster B is more of an emotional, personality disorders and impulsive. And then the third one is C, which is anxious. They're considered the anxious categorizations. Okay, so the first one in cluster A is paranoid personality disorders. They have a pervasive distrust of others. It's pervasive. Pervasive. We're talking duration. It's over a long period of time, years and years, that it has to be able to be presented, of distrust of others. Reads hidden meaning of threats into benign events. So it could be an innocent situation, but they're reading into it, that there's hidden messages that are negative, that are to be fearful, that are a threat to them, in a situation, or something that a person said that is non-threatening to others, but to them, they take it as being a threat to them, and so that's part of their paranoia. Lacks bias in their suspicions, so they're unable to, in their reality check of life, they're unable to see the facts as they are, without being suspicious most of the time. Again, frequency, most of the time, duration, over long periods of time. They mistrust people's intentions. Sometimes you mean to do something nice, but people with paranoid personality disorder will take it as, will flip it. It's not nice for them. It's, you try to, harm me in some way. You try to embarrass me. You try to make me look bad. You try to, they don't trust your intentions at all. Whether you say, it's good intentions, or it's to make you look good so that I could look bad. That's why you did good. That was your motivation. Other people are watching. I mean, they will always have an excuse that's negative for why you do something that you just out of the kindness of your heart, right? And so that's how they see, and they do with friends and family, romantic relationships, and with their spouses, it suffers a lot. So they see threats and danger in casual situations, which is what I had said. Schizoid personality disorder. This is also cluster A. They have a chronic detachment from social relationships. They are not able to interact, mend. Their functioning when it comes to being with others, whether social or romantic, is very, very difficult. Because as you will learn through attachment theory, detachment will be discussed. And so definitely you want to see that video just for average people who don't have a personality disorder, in their relationships, and, in their functioning, in their interactions with social and everyday life. That's a good workshop to look at. But for the schizoid personality disorder, it's very chronic. It's barely no friendships at all, barely no attachments with others at all. They're pretty much loners, isolate themselves. Lack of emotional expression. You can't tell if they're afraid, angry, sad. It's just like monotone. It's just in their voices. It's just no emotional display at all. Just very, there's a word for it. That's why I'm having it come to me. I'm sure you're out there going, oh, and you're saying the word and I'm not getting it, right? Let's see. They also have no desire in romantic relationships, not at all. They're not interested in intimacy. Difficulty relating to others because they, what they find interesting, other people usually tend to not find that interesting, or it's too over the top for them. What their conversations are about. And they choose to be by themselves, and they choose activities where they could be by themselves. And I give this example of Sheldon. I wanted to give an example actually of each one of them. Let's see if I could go back. But you know Sheldon from the Big Bang Theory. I think of him. I think that they based his character in the show after a schizoid personality disorder. Let's see. So for paranoid personality disorder, usually for each person, for each of these, I have met or I have diagnosed or I have counseled someone in each of the clusters. So I'm trying to think of a person that I know. Of course, I won't say. I did have someone, but I think I just diagnosed them. I didn't actually. I didn't actually counsel them. But an example always helps, so I'll try to do that. In cluster A, again, for schizotypal personality disorder, they're chronic social and interpersonal relationships, pretty much the same like schizoid personality disorder, that they have difficulty meshing and being intimate in relationships, or even just having casual social conversation. They're inept. Cognitive distortions and paranoid ideation. So again, they have this paranoia, and also how they think is distorted. Like when they speak about things, you yourself will find it odd, like that's strange. It's not the norm. And it's not until you hear them speak do you realize, oh, what they're saying, might be choppy, or they go from one thought to another, or their ideas are warped in some way. Their eccentric behavior, they're very eccentric. They don't do the norm, it's more than just being odd behavior. It's eccentric. It's not socially acceptable, I guess you would say. But for them, it's normal. Odd and magical beliefs. For example, they believe that they can mind read. That's just an example. But they have this, and it's not like grandiose thinking. It's more like that they can do things. They can move things with their minds. So many of the times there's some kind of magical beliefs with them. They find it hard to relate to others. And that's probably what keeps them at a distance from being around people. And people also reject their behaviors because they find it odd, but there's no psychosis present. That's important. That's an important fact. So you would think like schizophrenia, right? That they have some kind of visual or audio hallucinations, but there is none with schizotypal personality disorder. I did have someone who came into my office who I did see, and this person, and they had schizotypal personality disorder, and this person was odd, did have odd behaviors, some paranoia. When, for example, when she kept looking down at the table, and as they're looking down at the table, it's a glass table. And so I didn't realize they could probably see me on the other side through the glass table. So this is how they were the whole session, talking, looking at the glass table. So I just thought they were looking down. And they said, they asked permission, is it okay if I look down during the session? I said, sure, no problem. But they couldn't look in my face. They couldn't look in my eyes. They couldn't look directly at me when speaking. They had to look down. And I guess it was safer to be able to see me as the clinician talking back to them in the glass table than just to look at me straightforward. Even if they just looked to the side, that was still too intense for them. And so that was fine. So most of the sessions was they looking down, but I noticed as the session got better, they would look up every now and then, which told me that they had some growth. And then they would look down again. And then I didn't see them for a while. They were like, oh, and the reason why is because, they told me something horrific. And because I thought no one should go through that. And they thought that I was laughing at them. That's the distortion. And they said, why did you laugh at me? And I said, oh, no, I didn't laugh. I was just so surprised that someone would say that or do that to a human being. And they still took it as a laughter. So they didn't come back. And then through about maybe 2 months had passed. And then they came back. And they went looking for other therapists, but they came back. And so we continued and we picked up on them we had that rapport, I guess. So now they would look up, but never into my face. So that was, and they had no friendships and they didn't care to have any friendships. And this person was working a job, the same job. They were consistent, they were good at what they did, and they worked that job for most of their time. They liked dogs. That was their company, was their dogs, and that was their life. And and they visited family, but they didn't stay long. So this is the kind of personality disorder. This is the behavior that they had. And we developed a really good rapport. And, me being outside of myself, me being very outside of myself and very energetic and social, I tend to rub off on others. So by time, I think we saw each other maybe 1.5 years, and this person had been counseling for so long, but they were on medication too. So it was enough. I said, no more counseling for you. You're doing good on your meds. And they were just living a much better state of life and making strides to be with others. And that was so hard for them. And so to see them, like, they really progressed, really, really, really progressed. And it was in baby steps. I had to do baby steps, and even gave them a voice of advocacy for people who treated them wrong. We did skits of, okay, what would you say in this situation? And they did really well. They started advocating for themselves. And it was really, really a good example of a session with a schizotypical personality disorder. In cluster B, there's antisocial personality disorder. Usually when you diagnose someone with antisocial personality disorder, they have to have had a conduct disorder diagnosis before the age of 15. Then after 15, you could no longer put conduct disorder. You then put antisocial personality disorder. It leads into it. They have a disregard and violates rights of others. So their rights are more important over your rights. Exactly what it says. They disregard any, make it trivial, menial, your rights, not your words, not what you say or think, your rights. And they lack remorse. They have no guilt in the things that they do, and very little empathy. They could probably see it, but they don't usually take responsibility. So they have very little empathy. Failure to conform to social norms and to the law. And this is why it's a conduct disorder. Lying, conning. Hopefully I spelled conning correctly. I'm looking at it like, did I say spell conning? I think I have it right. Wrong. Lying, conning, and manipulating others. You'll find that in this disorder. They can be reckless. They have risky behavior. disregard for safety of themselves even. So they'll, drink while driving, promiscuous. They don't think. It's an impulsive disorder, so they don't think before they do this unsafe behavior. It could be like daredevil situations where they're just definitely not thinking. But again, it's all the time. It's not just a one-time thing. It's consistent. It's almost daily because it's part of who they are. Inconsistent in working and finances. It's very hard for them to keep a job because of their personality disorder, of violating people's rights, like I said, and having risky behaviors or reckless even, and their finances. They're usually, because of their behavior, doing drugs, with other risky behaviors, right? With drinking alcohol, with just anything that they don't see safe. They will engage in that behavior. And like I said, with finance, so usually they don't really have good finances, or they're not saving. Like I said, and they don't have a good job, or maybe it's spotty. They'll work here 2 weeks and then they lost that job and now they're going to work here, because sometimes too their personality disorders, they are abrasive too, in their conduct. So, they'll argue and they'll, so it's their lifestyle, that negative lifestyle that comes into the workplace, or, why they can't stay in school. So these are the things that prevents them from keeping a job, or being educated, or keeping good finances. Someone with anti-personality disorder. So I did know someone who they were actually 15, and I didn't want to give the antisocial personality disorder, although they had conduct disorder, but I gave them an antisocial personality disorder because it was very clear that throughout school, elementary school and on, that they had a conduct disorder. And so now they were presented in my office and they were 15. And it wasn't ADHD, it wasn't, it was a conduct disorder, which sometimes people confuse with ADHD. And so I gave them an social personality disorder, and they had very reckless behaviors. Even for such a young person, they had done things that adults would do. Stealing. They're not very honest. Like that's the manipulating. They're conning, lying. They can be very charismatic, even like very charismatic, just lovable, charming people, but it's all for some agenda, some hidden agenda, in order to do something or get something to enhance their behaviors. And I felt bad. I don't like giving personality disorders. I don't like it, but it is what they are. And so so that they could get better treatment. That's the whole reason, and make clear the understanding, because sometimes parents are like, I don't know what's going on. And sometimes having that diagnosis is like, okay, now we know what it is. Now we can move on. And what can we do for treatment? In cluster B is borderline personality disorder. They are usually unstable sense of self. They don't know who they are. They could even adapt what other people think of them because they don't know who they are. They have a fear of abandonment. They are afraid of being left alone, or that people would leave them in relationships that are close to them. or that they love, feelings of disassociation. And disassociation is like, it's like not feeling like you're yourself, that you're not in your own body, so to speak, but you're kind of outside of your body, seeing life that way. That's a disassociation. Some people have that. And sabotage themselves. You know, what they fear, they work towards not having or not happening. Eventually it happens to them somehow. They sabotage themselves. Chronic mood swings is a symptom. Very, very, very moody, very moody. 1 minute, very nice. Next minute, very agitated about something. They have this thing called splitting, which is the best way, I guess, to describe it. Splitting is like, it's a polar opposite. So there's no gray area for them. You know, it's either one or the other. And then it could switch. So, you know, they could like something 1 minute, and then they're in the same conversation, even they can say, oh yeah, it's da 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 da, you know, it's something negative about the topic that they just said was really nice or really good or positive. So they have that splitting. They find it difficult to be in the gray, to accept both spectrums of something. And difficulty controlling their anger. Yeah, they have it's very hard for them to calm themselves, and it's not usually a covert anger. It's usually overt. They have a distrust of others' intentions. They don't trust. Yeah, they don't trust. Why are you being so nice to me? Why did you do that for me? They know in their mind it's something negative. They're impulsive and unsafe and dangerous behaviors. So they're very impulsive and, oh, you know, let me, and it could be unsafe and dangerous, but like they could say, you know, I had someone say, oh, you know what, I want a Philly steak. I'm gonna drive I'm gonna take an Uber all the way from, you know, I don't know, North Carolina, I don't know, Virginia, and I'm just gonna take an Uber all the way to get a Philly steak and come back, right? They'll do things like that. It's like, so it doesn't have to be always unsafe and dangerous, but not the best or wise decisions. So I had someone who had borderline personality disorder. And this is a very difficult disorder to diagnose. If you're not familiar with borderline personality disorder, you can't really figure out what it is. But a key sign is if you feel exhausted, if you feel like when you're around this person, they literally suck you dry, you feel like just, you avoid them because they're going to take a lot. They're a lot to manage. It's not just drama, right? It's a lot to manage. It's their impulsivity. It's their emotional mood roller coaster. You know, it's their mood swings. It's like a roller coaster. It's really draining. It's their fear of abandonment. You're gonna leave me, and it's their impulsivity. It's their walk out on you, and like it's emotionally draining. If you feel like this, most likely, that is borderline personality disorder. Again, I would see a clinician about it first, but that's how you kind of know. That's the basic sign of borderline personality disorder. So definitely the mood swings and they sabotage themselves. And I had one client that every clinician that worked with them within our organization. She was being sent from one person to another to another. And then finally, they said, oh, have her work with Patrina. Because she was calling even, like she was calling people to report the clinicians. And this was going on their record. And so they didn't want to work with this person anymore. And they were like, well, have her work with Patrina. And I was like, oh boy. So, you know, I did take them on, and I did know the risks that would be involved. Like she could definitely call authorities on me too. And so for a long time, like I helped her with a lot of things, getting housing, getting, you know, working with her family, just different things I was able to get, even like food where she can go. And she was in and out of the house, and that was really hard. So like even her having her own curfew to keep her safe. I mean, all these things. And do you not know? And she said to me the first day, I tend to sabotage. So I just want you to know. And I said, okay. And she was really sweet. I was like, what is everybody talking about? She was charming. She was really, really nice. And then she, one day, you know, she just said, I'm calling, she reported me because I was 5 minutes late in picking her up. 5 minutes late for picking her up. And it wasn't for an appointment or anything like that she had to go to. And I was like, oh my goodness. I told her, I said, why did you call like this person on me and report me? And you know, your license is at stake, right? And I was actually a resident. So that was like more important like that. But thank goodness, like they understood because they had seen the record that she had been calling on other clinicians. So that kind of helped them to understand it wasn't my fault, but that this is the display of the personality disorder. And I asked her, I said, I need you to call them back and say that's not true, because she made up other stuff. That were very not true. Like that I wasn't helping her basically. And it turned out I was the one helping her more than everybody. And they were like, wow, Patrina, you were able to get a lot done that we couldn't get done. And she never thanked me or anything like that, but she would refuse to call and say, because I had to advocate for myself as a resident, you know, and she was not going to call and she was going to leave it the way it was. And that was how she left it. And then she didn't work with me anymore. You know, she left me, and she said, she did say, I tend to leave people before they leave me. So she probably figured I was still going to work with her if she had just said, listen, you know, my reputation was at stake here. No, I made a mistake. But she said, yeah, Patrina did not help me, and she was going to keep it that way. And so she just stopped seeing me before I could stop seeing her. So that's an example of borderline personality disorder. Histrionic personality disorder, most often seen in women than men. They also have a distorted self-image that needs others' approval. So they're attention seekers, you know, oh, how's my hair? Oh, how's my makeup? Oh, what do you think of this dress? They need that attention. Okay, now there are women who do that. Okay, that does not mean they have histrionic personality disorder. In the DSM, it's like 5 or 6 of their of these criterias that we're talking about that make up the disorder. If you have one, it doesn't say you have that personality disorder. But it's one of the criteria is that that they have a distorted self-image of themselves, so they need that attention because they think that they don't look good, that their hair is horrible, that their body is, you know, they have a poor body image. So there's a need for attention and to be noticed. They can be dramatical, theatrical, exaggerated emotions, you know, just always, they live in the always realm. Inappropriate sexual seduction. This is one of the criteria, one of the signs of histrionic, is that they are sexually seductive and they make rash decisions with threats sometimes of SI is suicidal ideation for attention. So, you know, I'll kill myself, you know, if you don't stay with me, or you think I'm this horrible person, I'm going to kill myself. So they'll threaten to kill themselves to stay with me. If you don't stay with me, I'm going to kill myself. So that's a way of using suicide ideation as a threat. And sometimes with sexual seductions, they can imagine that other people are thinking that way also about them in that way. And so they're very flirtatious. I should have put that in. That's like seduction, but a better word is flirtatious. They're very flirtatious. They think that the other person is flirting with them. And so that's their inappropriate, but it's over exaggerated as well. And I have known two people like this, and one was, flirting at work. They're at work and they were flirting with someone who maybe they were flirting back, because they said that they were flirting back, and this person was married, and the person with histrionic was married, and so they believed that this coworker was flirting with them, and they were very flirtatious with them as well. But again, it's to fill the need of the attention that they were getting from the person, and not knowing if they would be sexually involved or not. But there definitely was that, I'm so in love, being a schoolgirl, I'm so in love with this person, just an extreme in the moment, and in the moment kind of feelings. So that's histrionic personality disorder. Then there's cluster B, which is pretty popular, narcissistic personality disorder. They have an inflated sense of self and importance with entitlement. So they have the sense of entitlement, the sense of who they are, an inflated sense of self, a superiority, you can say. They look down on other people who are not similar in their mind to the same level or stature as themselves. They have an excessive need for attention, and not just attention, but they want to be admired. They want to be doted on. They want to be praised for what they are doing. They have thoughts of that they are brilliant. They have thoughts of brilliance. They can be brilliant, which is the truth. Not necessarily like IQ, but they can be very put pieces together. The processing can be very intellectual, and they have thoughts of being good looking, and they can be good looking, but it's this arrogance, that they're so smart, and a boastfulness, that's what I should say, being so good looking, thoughts of power. This is something that they thrive on, and success. They thrive on attaining power and success, and they insist on having the best. nothing but the best for them. They exaggeration of their achievements and their talents and their gifts. They have a lack of empathy to recognize the feelings of others. So that's another sign. That's a key sign of narcissism, is a lack of empathy. They have a difficult time caring for other people. And when I say inflated, and when I do these things, it's so that you could understand the personality trait, the personality persona that narcissism brings. And so that's why, because it helps you to identify it, because sometimes it's hard. People don't necessarily, they're like, I'm having a difficult time with this person in my marriage with my wife or my husband. I'm having a difficult time with this coworker, with this family member, but I don't know why. There's such a blank, there's such a annoyance, they tend to be name called for being mean or rude, snob, and so sometimes that's a sign that maybe they're narcissistic. And so these are some of the traits of a narcissistic person. And so they're very hard in therapy. It's very hard. It's not like it can't be done, but they have a hard time in therapy, but it can be done. But people say that it's hard to counsel a narcissist, but it can be done, experience and definitely there's treatment, there's more treatment and coping, how to help them. There's a few like workshops, workbooks that has come out to really help people with narcissistic personality disorder. So it's definitely doable, although I read that it's difficult, but it can be done for sure to help them. Okay, so avoidant personality disorder is in cluster C. They feel lonely, isolated, and inferior to others. They avoid activities and groups due to expected feelings of criticism and disapproval. They worry about being found out. I should have put that in quotes. They worry about being found out, that they're not truly who they say they are. They're not as good at what they say they are. And they worry about just being rejected by people, I put so in there. So will avoid relationships and friendships. They will avoid relationships and friendships. Oh, I see. Okay, so as a result of worrying about being found out and worrying about being rejected, they will avoid relationships and friendships. They're not willing to try new things for fear of embarrassment. They don't like to be embarrassed. And so they will avoid at all costs. So the things that mostly they will avoid is criticism, any disapproval, any embarrassment, and any rejection. And so they just avoid it. They can't cope. They can't take that. And so in order for that not to happen, it's too much for them. It's too overwhelming. It's too much for them. They tend to say, I'll just be by myself. I don't have to deal with humans, And some people, and some avoidant personality disorders, they'll say that, I don't like people. I don't like people. I don't want to be about people. I like my cat. They just don't like to be in, oh, come to lunch with us. No, that's too much for them. That's overwhelming for them. Hey, we're gonna, do, this Christmas party. No, that's okay. I won't go. They just avoid because it presents like a serious shyness, I should say, from knowing clients who have avoidant personality disorder. It's, and you have to be careful because they're coming to therapy. And so you have to be very sensitive to them. That's very important when you're working with people who have APD. And so, you just have to be careful. I forgot my train of thought, something that I wanted to say, maybe it'll come back to me, because there's so many thoughts going on in my head about this. Oh, yes, they look very shy. They could present as very shy, right? But there's shy people and there's avoidant people. And sometimes, knowing the difference between a good clinician knows it's the difference between like avoidant personality disorder and maybe someone who's just extremely shy or social, or has a behavioral social phobia, which is more of a behavioral than a personality disorder. So, but avoidant definitely looks like they don't want to do anything. They don't want to go anywhere. They just want to stay home. I mean, if you know people like that, again, it has to be certain criterias, 5 out of 6, 6 out of 7 in the DSM in order to diagnose that as avoidant personality disorder. It's not just one thing. Dependent personality disorder is in cluster C. These people have difficulty making daily decisions and need input from others. They have a hard time making their own decisions. They may take a long time to make a decision. It could be shopping. Should I buy this in the store? Do I need this? It could be anything. Should I go on this life path or this career, this job? Should I go to school, not go back to school? Everything in life. Should I cook this? They have a hard time making decisions, and they're also always, what do you think? Pulling in people to get their opinion and what they think would be best for them. They're not able to make that decision for themselves. It's a very chronic inability to make decisions for themselves. They're afraid of being alone to be responsible for themselves. So they don't like to be alone, right? They don't like to, on their own, make decisions. And they have a hard time taking care of themselves and being responsible for themselves, of all the things that they need to do. They have a hard time, even just living by themselves. They prefer to live with someone else. They prefer being in relationships all the time. Even in dating relationships, they find it hard to be alone. They'll pull in a sibling or someone because it's not that they don't want to be alone. It's that, or like to be alone, is that they need the support of other people because they can't do it by themselves. Although they don't know why, they just think they don't realize maybe that they're not capable of being responsible and independent. They just see it as a need for pulling in friends and family, but it's very needy to others. That's how it presents, that's how it looks. They'll agree to doing something wrong or something they dislike doing just to avoid not having support, or just to avoid being alone. They will do something wrong or something they don't like. They'll tolerate just so that that person is there. You see this in relationships sometimes, and definitely in relationships that are domestic violence. They'll put up with a lot of the abuse because they don't want to be alone. They don't feel they could take care of themselves. Maybe they don't have the right education. Maybe they don't have skills for working. So they stay with the person um, and they don't believe they can do more than they are doing. So they stay with the person, they stay with the abuser. That's an example that I have seen for domestic abuse. And so, you know, they have that term codependency. And that is, you know, a behavior, but it's a behavior, but this is a dependent personality. They have been all like that all their life. They have a low self-esteem, with others, feeling others are more capable than they are. And so their self-worth, self-esteem is very, very low. All right, I think this may be the last one. Obsessive compulsive personality disorder. So there's obsessive compulsive disorder, right? OCD, and that's a behavior. You know, that's an onset that happens, you know, maybe in teens, but this is all their life to have this personality disorder. They have has a deep need to control, with their way being the right way. I should put being. They're being the best way. And so they have this sense of control. They need to control things. You know, it brings them relief. It brings them calmness to be able to control their environment, because they feel like it'll keep them safe and other people safe. And that's the root of it. They have anxiety with perfection versus mistakes. And so that's why they have the sense of control, because it's an anxious behavior to perfect something and to prevent mistakes. So they fluctuate between those two. 4 types, they're now categorized as 4 types of obsessive compulsive personality disorder, which is a checking. They're continually checking on things. I know someone who has obsessive compulsive personality disorder who continually makes a checklist of things, that things are done. And so they cannot be spontaneous if their daughter says, hey, come with me, you know, let's go shopping, let's get our nails done. They are unable to leave the list because there's things on the list. They have to do the list first, or incorporate take someone off the list to incorporate going out at that certain time on the list that's free for them to get their nails done with their daughter. That's an example of a client that I had. And so that's a checking. But they just saw it as being responsible. I'm just being responsible, but it's affecting their functioning. And so that's where you know, you say, okay, it's more than just a checklist. They have with contamination. That's another thing. It's a physical or mental contamination. So physical, of course, washing of hands all the time, using alcohol, that I can't think of it now. Hand sanitizer. Thank you. I feel like you're like what you would have said came to me. Yes, hand sanitizer. So it can be physical with germs, and it could be mental with like moral, the superego, basically, you know, having morals, being free of guilt for something, morals of what's right, or religiosity. And so there's a compulsiveness for that. Order, also to be organized, that there's order, that the things are symmetry, that things are not out of place. I had a young boy who was that way. It's like, you know, he had his trains, not one thing could be moved out of place by his little brother. No. And then it was like a meltdown, full meltdown, because it was touched, it was moved out of place. He had everything in order, spaced perfectly. And I said, wow, you know, you could really use that when you get older. Like that's going to be an asset, but it's a double-edged sword, you know? So let's see, rumination. Also, rumination of, this is the fourth type, rumination of thoughts and intrusive thoughts. So like your mind is racing, right? Racing thoughts. And rumination, which is consistently thinking about a situation, what I should have said, what I didn't say, what I should have done, what I didn't do. When they said that, I should have said that. Like it's just going on and on and on. Or, you know, it doesn't have to be about a social thing. It could be about, you know, oh, did I wash my hands? Did I turn off the stove? Did I lock the door? Did I, you know, so it's always a thinking, a rumination. And recently they put in the DSM-5 hoarding as part of obsessive compulsive personality disorder. So for hoarding things and cluster. So it could be the opposite. It's not, in their mind, there's order, you know, there's clutter, but the clutter is ordered. There's order to the clutter, right? We may see it as hoarding, but they don't see it as that. They see that they're organizing things, and it's a compulsion to have this thing because it's bringing, like, again, comfort. So something I learned in my college of the City College of New York, something that I learned was in my 101 psych classes is everyone does something. There's two things human beings do. They avoid pain and they embrace pleasure. That is the human foundation for all of us. We all want to avoid pain and we want to increase pleasure, right? So that's the basic need of every human being. And so in obsessive compulsive personality disorder, this is what, you know, you can see it very clearly that it's this need to avoid disaster or unsafeness, in a sense, to calm their mind and to prevent and to be safe, right? So this is the foundation to why they're checking and worrying about contamination and putting order to things. It brings relief. It brings relief. And why they ruminate and why they hoard. Sometimes it brings pleasure, you know, it's associated to someone they love. And so they'll keep that, or they'll keep, you know, they'll keep trinkets and things that make them feel good. And so that's in all of us, you know, whether we have a personality disorder or not. That's just basic human behavior. And that is it. So thank you so much for coming. So grateful that you were here with me during this series. I'm very thankful as we're closing out the year of 2021 that I stuck to my promise, because I really wanted to present these workshops, right? Because of the pandemic and people saying, hey, you know what can we do? We're all stuck at home. And so how wonderful, you know, the chefs came out, the exercise gurus came out, you know, we all developed talents and we shared our talents and our gifts with each other. And it really brought us all together, you know, and it made us unified. And we all became technologically savvy, and we hosted virtual programs, and we worked from home, you know, those who were able to. And so 2021 really had some highlights. It really did. And we're moving into 2022 But this is one of the reasons in 2019, around November, December, people were asking, well, what could we do? Because we're stranded at home. And so I thought, okay, what can I do? And I said, well, you know what? I love social sciences and I love all the different topics. And some people, don't know about the topic. I could totally research it. And I have research at my fingertips being a PhD student. Let me bring it to the masses. And so, I based it off of all the topics, social science topics and spirituality, on the leading resources. So when there was research, I used research journal articles that were peer reviewed. If it was the Bible, if it was spiritual, and we talked about scriptures, we went right to the Bible for it. The DSM, if we talked about personality disorders or therapy, counseling, definitely we brought that. We used the DSM. So, I wanted to make sure that I was being factual, as well as bringing out these really interesting topics. And so you can see them on Stories in Mental Health on Facebook page. I will be posting, and you can let other people know. As my mom said, people view, there's so many viewers, but nobody subscribes. And so she's like, tell your audience, you know how sweet moms are. So I'm telling my audience, please subscribe so that the videos could keep going. I did 12, one a month. That was the plan. And from there, I got sideswiped a little, but because of doing my dissertation, which I'm not complete. So pray for me, send out those positive good wishes for me to really complete it and be successful at it, and be published, which is what I hope. It's on resilience. And so how interesting, to be able to apply to the masses. But doing these videos were such an honor, and so encouraging from all of you. And so please subscribe. And there's one more video that's going to be out, which is the video on prayer, and I will send it after this one. This is the 11th, the 10th or the 11th. I think this is the 11th video. And so prayer is I went to close out the year with the prayer one. So it's been a pleasure. It's been a pleasure. I appreciate everybody who came on during my live audiences, asking questions. And then I realized, make it even simpler and just record the video and send it to whoever wants to view it. But it was fun. I tried to switch it up. I tried to co-host with different people who were key experience on the topic. And it was just a wonderful journey for 2021 for me in presenting these workshops. So thank you so much. And may 2022 be an amazing year for you and your family. Bye.